Today, we're unpacking an absolute heavy hitter in neuro-oncology, the meningioma. If you're looking to really master the clinical presentation, the underlying genetics, and the precise pathology of these tumors, you are in exactly the right place. We're going to take a highly structured macro to micro approach, looking at exactly what these tumors are, why they form, and what they look like under the microscope.
All right, let's dive into our roadmap for this explainer. First, an introduction to define the tumor. Next, etiology and genetics, followed by gross and microscopic morphology. We'll then cover WHO grading and finish up with a fantastic mnemonic recall strategy.
Section 1. Introduction. Defining the tumor. To truly understand this tumor, you have to understand its origin. Meningiomas are defined as tumors arising specifically from the meningothelial cells of the arachnoid matter. And to be even more specific, they originate from the cap cell layer of the arachnoid. This is an absolutely vital distinction because it dictates exactly how these tumors behave. They aren't actually brain tumors in the sense that they grow from brain tissue itself. Rather, they grow from the linings that surround the brain and spinal cord. Now, you might be wondering just how common these are. Well, meningiomas represent a massive portion of neuro-oncology. In fact, this family of tumors accounts for a full 20%, literally 1 in 5 of all intracranial tumors. When you're looking at brain imaging or studying neuropathology, this is a topic you simply must be familiar with. So who actually gets them, and where do they show up? Demographically, they're usually found in patients spanning from their 2nd to 6th decades of life. There's also a slight female preponderance, which is a massive clue we're going to connect to their molecular biology in just a minute. Clinically, these are mostly benign and generally solitary tumors. While they can be multiple, especially if associated with certain genetic syndromes, they very rarely become malignant or metastasize. If they do, it's mainly to the lungs. As for location, their most common sites are right in the front half of the head, including the lateral cerebral convexities, midline along the falx cerebri parasagittally, and the olfactory groove. Section 2. Etiology and genetics, the molecular blueprint. When we look at the genetics of meningiomas, one abnormality towers above all the rest, accounting for more than half of all cases. We're talking about the monosomy of chromosome 22, specifically an allelic loss of 22q12.2. So why does this matter? Well, this specific locus encodes the NF2 gene. The product of this gene is a protein called myelin, or schwanninoma. When this gene is defective or missing, the lack of this crucial protein simply paves the way for meningioma formation, which is exactly why multiple meningiomas are heavily associated with neurofibromatosis type 2.
Beyond chromosome 22, there are several other established etiologic risk factors we need to track. Excessive exposure to ionizing radiation is a big one. Now remember that female preponderance we mentioned earlier? That ties directly into our second point, excess progesterone hormones, driven by the presence of progesterone receptors right there in the meningioma itself. We also see syndromic associations, not just with NF2, but rarely with navoid basal cell carcinoma syndrome, which is also known as Gorin syndrome. Add to that familial incidences involving genes like NF1, VHL, PTEN, and PTCH1, alongside lifestyle factors like an increased BMI and smoking.
Section 3. Gross morphology, the physical tumor. Grossly, a classic parasagittal meningioma is a well-circumscribed, solid mass. It typically has irregular surface convolutions and really prominent blood vessels. A defining physical feature is its broad-based, firm dural attachment. You'll notice peripherally adherent, thick dural tissue right at the top. But here is the most important clinical takeaway. Watch how the mass is indenting the surface of the brain. It compresses, but it rarely ever invades the brain tissue itself. The cut surface is firm and fibrous, and occasionally the overlying bone might even show hyperestosis.
Section 4. Microscopic morphology, the cellular level.
Down at the cellular level, the microscopic fingerprints of most meningiomas are absolutely unmistakable. The first thing that jumps out is these beautiful, concentric, swirling patterns. That's the classic whorled arrangement of tumor cells. Right in the center of those whorls, you'll often find dark blue calcified cores. Those are the famous summama bodies. You'll also encounter spindle-shaped fibroblastic tumor cells, alongside more solid syncytial tumor cells that have much less defined borders. Those microscopic features help define the 3 most common histologic subtypes, though it's crazy to think nearly 15 have actually been described. First up is the meningotheliumatis, or syncytial subtype. This one resembles normal arachnoid cap cells, with solid masses, whorls of polygonal cells, and indistinct, poorly defined cell membranes. Second is the fibrous or fibroblastic type. This features spindle-shaped cells forming parallel or interleasing bundles. And here, whorls and psammoma bodies are far less common. Third is the transitional or mixed subtype. This one perfectly blends the syncytial and fibroblastic features, showing conspicuous whorls that often calcify into those classic psammoma bodies. Just remember, these represent a spectrum of lesions, not three completely isolated entities.
Section 5. WHO grading clinical behavior.
So, how do pathologists actually categorize the severity of these tumors? That's where the WHO grading system comes into play. It's based primarily on two things: brain invasion and mitotic count. Grade 1, which captures those common syncytial, fibrous, and transitional subtypes we just discussed, has a low mitotic count of less than 4 per 10 high-power fields. Grade 2 tumors are uncommon atypical variations, think clear cell and choroid types, showing 4 to 19 mitoses per 10 high-power fields. Finally, grade 3 tumors are frankly malignant and anaplastic. They're rare, they have a mitotic count of over 20 per 10 high-power fields, and crucially, these are the ones that can display features of anaplasia, invade the underlying brain, and cause extraneural metastases to places like the lungs. When we translate those clinical grades to actual patient outcomes, we see a pretty stark contrast. On the highly favorable side, 90% of most meningiomas, these are your standard grade 1s, can be successfully removed surgically without any residual changes. That's a great metric. However, the real clinical challenge arises with grade 2 atypical meningiomas, where recurrence becomes a huge issue, happening in up to 30% of cases. And of course, while rare, those grade 3 frankly malignant meningiomas can be lethal.
Section 6. Mnemonics for recall, retention strategy.
To lock all these complex facts in, we're going to use the word itself, Meninges. M stands for monosomy 22, the most common genetic loss affecting the myelin protein. E is for excess progesterone, explaining that female preponderance. N is for the NF2 gene association. I reminds us of the ionizing radiation risk. The second N stands for that highly favorable 90% removal success rate. G reminds us that grade 1 is the most common. E stands for extraaxial, meaning the tumor compresses and indents the brain rather than invading it. And finally, S stands for the syncytial and spindle cells you'll see swirling under the microscope. If you take away just one core concept from this entire explainer, let it be this. Meningiomas are highly prevalent, genetically rooted tumors, heavily tied to NF2 and chromosome 22, that are largely benign and beautifully circumscribed. They arise from arachnoid cap cells to indent rather than invade the underlying brain. And recognizing those distinct whorls and psammoma bodies under the microscope is your absolute key to diagnosis. We know that high-grade meningiomas exhibit far more complex genetic changes than just the standard NF2 deletion. So I want to leave you with this provocative thought. As we continue mapping these highly complex genetic mutations in anaplastic grade 3 variations, how might future targeted molecular therapies finally unlock cures for that most lethal, aggressive fraction of these tumors? It's a thrilling frontier in neuro-oncology for sure. Thank you so much for joining me on this explainer. Stay curious, keep studying, and I will see you next time.